So rapid sequence intubation, this is the actual definition that the book will give you. The near simultaneous administration of a sedative hypnotic agent and a neuromuscular blocker in the presence of continuous cricoid pressure to facilitate endotracheal intubation and minimize risks of aspiration. Modifications are made dependent on your clinical scenario. Some people will still try to call it a rapid sequence intubation if they only give the sedative. That's not what it is. If you don't give that neuromuscular blocker, it is not considered a rapid sequence intubation. But depending on what the scenario is going, is if the physician or the practitioner is performing the intubation might need to do some modifications with it. What's your advantages of having an RSI? It optimizes intubation conditions. It facilitates visualization because your patient's not fighting you. You don't have to worry about them trying to bat you around, their tongue's not moving around, getting in the way of you trying to visualize your cords. It has a higher rate of success, and that has been proven in multiple studies, is that an RSI intubation will have a higher rate of a first-time success rate. Decreased time to intubation, much quicker because you're attempting less times. Most of the time you're getting it on that first, if not the second try. Decreases your risk of aspiration because you're taking away the drive, you're neuromuscularly blocking, so they're not going to vomit on you. And attenuation to your hemodynamic and your ICP changes. Okay, so we're kind of protecting everything if it's possible to give an RSI. Now we all know that it's not always possible to do an RSI. There are contraindications. If you are worried that you're going to have difficulty with that endotracheal intubation, whether maybe it's an atomic disorder, if you really feel that you're not going to be able to get that ET tube in, the worst thing to do is to RSI that patient because now you've taken away all of their own respiratory drive with that. So we want to make sure that we're very comfortable with being able to intubate, and if not, do we have a backup plan with this? Goes along with the lack of operator skill or familiarity with that, and your inability to pre-oxygenate. Okay? If you do not have really good bag valve mask, it's going to be difficult to get chest rise once you have paralyzed that patient. So if you haven't already pre-oxygenated prior to the RSI, you want to go ahead and realize that you're going to have a little bit harder time once you actually have given those drugs. So complications. Post-intubation hypotensive. And we've already talked about that you can be hemodynamically unstable with this. What happens is the loss of that sympathetic drive. It's not there. The increased incidence of MI. Did you cause a pneumothorax with this? Have we caused auto-PEEP? Depending on how fast the patient was breathing, how fast we're bagging for the patient. Those are all post-intubation leading to what a hypotensive. So if you were hypotensive, those are some of the things you want to look at. Medications, the complications with those. Inability to secure that airway. If we give that RSI and we can't intubate that patient, then now we have a difficult airway, and we have no ability to be able to secure that. You increase your vagal tone with that second dosage. You've got a histamine release. Now that one's rare, but that is a possible complications from your medications. And again, you're increasing that ICP, your IOP, and your intergastric pressures.
Now for people at home, we have had some questions about auto-PEEP that have come up. Can you define that, please?
Yes. Auto-PEEP is the air trapping overextension of the lung and the excess post-expiratory pressure that is being left inside of there. That is the pressure that the patient cannot exhale out. So that is added on. If you have 5 a PEEP set, and we tell you have an auto PEEP of 8, that means there's 3 more centimeters of water pressure of PEEP that is now sitting inside of the lung that the patient is unable to exhale, which means your patient is not able to effectively ventilate themselves. And later on in the lecture, we will go over a little bit more on the auto PEEP too, and some of the techniques to be able to kind of get rid of that.
Okay. Thank you, ma'am.
Thank you. All right, capnography. All right, so in a capnography, we want to go ahead and use that with any intubated patient if at all possible. We have that available for us, and I know that most of the trucks are carrying them, and we have them on all of our code cards and without to the hospital. We know capnography is an essential tool. One of the things it can do is verify our endotracheal intubation. It's perfect and wonderful ET confirmation during transport. We know how they get tousled and bumped around, so having capnography all the time to be able to watch that waveform is a wonderful way to ensure that we're remaining intubated. And it also tells us the efficiency of our compressions, because now we're able to see how well are we ventilating that patient with our compressions. So we've got a couple of different waveforms over onto the side here. Now, normal square box waveform, that means your baseline CO2 is 0. You're looking at it, that you're within that perfect range of your end-tidal CO2 of 35 to 45. That's exactly what you would want to see on a perfectly normal patient, which we know is probably not going to happen, right? So now, well, let's look at what some of the waveforms would look like depending on what's going on with our patient. So if we had a misplaced ET tube, you're going to lose your waveform, which means you're not going to have any end-tidal CO2 reading. So the management of that is to replace our to replace our endotracheal tube if all possible. But you will have the waveform. You're going to have a regular waveform, and then once you lose that intubation, it's going to go ahead and go flat because it's not going to detect any returned exhale CO2 from the patient. If you get it into the esophagus, okay, there we go. Okay, that means we have no waveform whatsoever because we're not actually intubated, so we're not going to have any exchange of CO2 there. And then the management of that would be to go ahead and intubate. When we're performing CPR, you would like to see square box here, where you're going to have your baseline is CO2 is going to always go back to the 0, and you're going to run a CO2 of anywhere from 10 to 15, sometimes higher. It's going to depend on how adequate that CPR is. Okay? And we want to go ahead and make sure that we're staying greater than 10 millimeters of mercury if we are during a CPR with this. Okay, and then we have our shark fin. Now this is without prolonged expiration. So this is what you would see in a patient that is having a bronchospasm. So that's the patient that we've just intubated. That's an asthmatic. That's a COPD, or maybe they did have an allergic reaction to something that they've inhaled. So what do we need to do? We need to go ahead, and these are the patients that you actually want to administer a bronchodilator to. And once you're administering that medication, you'll actually see a change in your waveform as the patient's lungs start to open up and they're actually able to get that CO2 out. And you had asked about auto-PEEP. This patient population of the asthma and the COPD, those kind of patients are the ones that are going to be more than likely to have auto-PEEP going on. And what's happening here is that you can tell the patient is unable to completely exhale out the volume that they're already getting in there. And so once we give the bronchodilator, you're going to be able to see a much better exhalation. All right. This one here, the patient's breathing too fast. Okay. Or we're breathing too fast for them. So the patient's rebreathing their CO2. As you can see, it's just steadily climbing higher and higher and higher. So we want to make sure that we've got adequate oxygen flow, make sure that we do have oxygen coming out of our ambu bag, and allowing the patient time to exhale. This happens when everybody gets a little excited. They're going to start bagging really, really fast. Slow down. Count. Make sure that we're allowed to exhale, because again, that's where you're going to be adding in a lot of that auto-PEEP and overexpansion of your patient's lung. So hypoventilation. That means we're not bagging fast enough for them, or they're not breathing fast enough for us. So it means you got a low respirations with that. So you're going to be looking at an end-tidal that's going to start reading greater than 45 millimeters of mercury. So what do we need to do? Well, we need to assist with their ventilations, or if we have not intubated them yet, then we need to go ahead and intubate them, because this isn't going to be adequate ventilation. So hyperventilation. Okay, with this, our CO2 is going to be less than 35. What we need to find out is if our patient is conscious, we need to talk to them. If they have a decreased assisted ventilation rate of the unconscious or intubated patient, we need to take control of that. Sometimes these patients will auto-cycle in a ventilator, which means that the sensitivity within a ventilator is set too low. And so any type of flow that the ventilator is allowing to come through, the patient's taking a little tiny breath. These are very ineffective breaths, and it auto-cycles the machine. So what do we need to do? We need to take control. This might be that patient that we're calling for some sedation for. To take away some of their respiratory drive, let us go ahead and breathe for them. You will see this in neuro patients. They will do a lot of this, a lot of excessive respiration. So. Now, if you're breathing around the ET2 is our last one over here. And what this one is doing is you got a leak. You got a leak around this here. And so we want to make sure that we check our patient. If this is an adult patient, is our cuff inflated? You know, even our pediatric patients, some pediatric endotracheal tubes do have cuffs on them. Starting at about a 3-5 endotracheal tube, you can get a cuffed tube, depending on where you're at and what supplies are being carried. You know, even on our emergency department, we have a mixture of cuffed and uncuffed. So we always need to make sure which one we have placed in there. But if you have an uncuffed tube, then maybe the tube is too small and we need to get a bigger one. If you do have a cuffed tube, did we inflate it? Has it been properly inflated? Do we have a leak? Is there a leak in the balloon or in the cuff? We need to figure that out. So what we need to do is check on our patient, see how well they're oxygenating and ventilating, and do we need to re-intubate or do we need to fix the cuff? Oops, sorry. Uh-oh. All right, how do I get it? There we go. Okay.
Now,
sorry about that.
Is there going to be any capnography change if, like, the tube dislodges when we're sliding them over and we end up with the tube, like, in the right main stem?
You're not really going to see a whole lot of difference with that because you're still getting an exchange of CO2. What you will see is if you're already on the ventilator, you're going to see an increase in your airway pressure.
Okay. So that's not something we'd see on the capnography, but we would have some sort of indication besides just the chest rise involved.
Exactly.
Okay.
If you are on a ventilator, you're going to see an increase in your peak airway pressures. Okay. It's going to let you know that. And if you're bagging the patient, you might feel as if the patient is all of a sudden became a little bit harder to bag. Okay.
Okay.
All right. So this is your failed airway algorithm. And basically, this just talks about if you can get the ET tube in. So failed airway criteria. That means failure to maintain an oxygenation. Okay. Do we have to do a cric? And we're going to talk about that. Or no, we don't. We're going to go ahead and we're going to choose other methods. You know, there is fiber optic, video laryngoscope, bronchoscopy, EGDs. They have lighted stylettes, and you can do a cricotomy. Now, this is all dependent on what do you have available. We don't all have all these fancy tools available. Even our emergency department doesn't have everything. And do you have the personnel that are available to perform these things? So do you have a cuffed ET tube placed? We want to make sure that, yes. So now we want to start our post-management with our patient. And you want to make sure that you arrange for some definitive airway management, and that's what we're going to be talking about next. So once we get that ET tube in, now we're ready to manage that patient a little bit better. Okay. Oh, sorry. Indications for LMA. My thing's a little crooked there. So LMA insertion. Now this is for that patient that's that difficult airway. So let's say we RSI'd our patient. Nobody can get the ET tube in. So where do you go next? You go to an LMA. I know that we also have the King Airways. So we want to go ahead and go with that sort of a device. So we're going to be looking at the LMA. So why do you want to use it? If the patient is difficult to bag, if you're unable to get good chest rise with it, and nobody is available to get that tube in, or we've tried numerous times, we cannot get a successful endotracheal tube in. It can be used as a last-ditch effort where the surgical airway is the only other option, but you don't have anybody else, you don't have anybody available yet. We want to provide an airway for the patient at that moment, so we want to go ahead and insert either an LMA or a King airway until we can get somebody that can come in here and help us a little bit more. So size guidelines. Now the size limitation is always a thing that's going to depend on the type of patient that you can deal with. Now if you see, the size 1 is the smallest that you're going to get. Now this is whether it is a disposable or non-disposable. We don't see many non-disposables anymore, but there's still some out there. Those size 1 is only for under 5 kilos. So you have a size limitation. This is not going to fit into every single baby that is out there. Remember that. You can attempt it. But don't be surprised if you're trying to put it into a premature baby or even a full-term baby that's smaller if you don't get good ventilation with it. It does have a size limitation, unfortunately. King Airway is very similar. I believe your King Airways go down to around a 2, I believe. So again, you're looking at still a kilo issue with that. But we go all the way up, size 5 for a large adult, and if you get a poor seal with your size 4. So now this is the process of inserting it. Right up here, you're going to go in. You want to make sure that when you're inserting an LMA or King Airway that you slide down the palate. You don't want to try and just force it down right past the tongue. If you slide down the palate, it's going to lift that tongue up and out of the way and help prevent an obstruction. And I'll show you the next couple of pictures are actually going to show what happens if we don't get it pushed in quite correctly. It does show using your finger or a tongue depressor to ensure that we're getting the cuff down to the airway as best as possible. And once you've got it completely inserted, you want to go ahead, inflate your cuff with the recommended amount of mLs of air that the cuff, it says on the LMA itself. And then you want to use your end-tidal CO2. You can use end-tidal capnography with this just like you would an endotracheal tube. You're going to get just as good readings with that. So we want to make sure that we are utilizing that.
Now in the field we have the OPAs. Can we use the OPA while we're inserting the LMA to keep the tongue out of the way?
Yes, you can.
Okay.
Yes, you can. So some of the problems that can come up with putting an LMA in or a king airway. If you don't press the deflated mask up against that hard palate, or you don't have enough lubrication, or the deflation can cause that mask to fold on itself. That's one of the reasons when I'm teaching LMA insertion, I always teach to leave a little bit of air inside of your cuff prior to insertion, because it gives it a little bit more of a substance to your LMA. But always make sure that you apply lubrication to the back portion of the LMA and along the side edges of the LMA to ensure that you're not pushing up against any hard areas that you can't get past. So with this, if you look at it, if you go ahead and start going down, it starts to fold over, it's going to continue pushing down and it's going to go into a down-folded position, and it's going to be a mechanical obstruction. You're not going to be able to ventilate at all. This is when you're going to bag and you're not going to be able to get any airway pressure in there at all. You're not going to have success at all with that. If the tip is deflated too far forward, it can push that epiglottis, causing an obstruction also. And you can either have, if it's not deflated to an adequate amount, you're going to push the epiglottis down and you can penetrate the glottis. Now that is rare. I can't say I've heard, but maybe one time of it actually penetrating the glottis, and that was a patient that had multiple traumatic intubation attempts, and then the placement of an LMA. So you never know exactly where the trauma came from, but you do have to be careful pushing it in there. Okay, your cracks. Now this is all pre-hospital emergency. Again, it is rare that we do these. Most of the time we have a lot of other airway adjuncts that we can do prior to having to go to that surgical need. But if we we're going to go through just a couple of slides to show you kind of the placement of that. So the creation, you want to make an opening space between the thyroid cartilage and the anterior inferior border and the cricoid cartilage, the anterior superior border of the access subglottic airway. So now this is something that unfortunately you do have to have someone that knows what they're doing with this, and you want to make sure that you have the supplies. Now there are some nice ones, and I'm not sure which teams carry what, but there are some nice ones that are the quick crikes that basically they are almost look like IV tubing, and they go in and turn and it's in. And it's very quick and easy to put in. Again, I'm not sure exactly what teams carry what and what the criteria are for those. But that is something that they do have available for pre-hospital too. So some of the contraindications and complications that you can have with a cric. Now this patient, I'm not sure that they would be able to get a cric in anyways. But this would be your patient that you do not have an oral or nasal landmarks to be able to place an endotracheal tube. So you would have to go straight for a cric. So contraindications, massive trauma to the larynx or the cricoid cartilage. So obviously if you're going to have massive damage below into the neck area, this is not going to be, again, your landmarks are going to be gone. You're not going to be able to place this. Damage to the affected structures, obviously it's going to be impossible to do it. And alternative or less evasive maneuvers of ventilation. So obviously if you can put anything else, please let's do that. Complications, hemorrhage, esophageal perforation, tracheal perforation, a TE fistula, infection, abscess, and sub-Q air. And these are things that we have seen with all patients out there. Right? It is truly a last-ditch effort. Retrograde intubation. Now, I myself have never seen this performed, but your certification talks about this, so I'll go ahead and include this. So this is for that patients that are breathing, but they have some sort of an anatomical problem that makes trying to do an oral intubation or nasal intubation fairly impossible or dangerous. So they have something in there that's blocking us from being able to do a regular intubation. So they say it takes up to 4 minutes to accomplish. Now this is obviously a sterile procedure. And as it says, it's not useful in the critical emergency care situation. But this is something that you could possibly see in an emergency room on that stable patient that they have time to do this one. Hopefully we're going to go ahead and take them down to the OR. Would be obsolete, but that's what we would hope for. But if you can bag valve mask this patient, then just do not go ahead and do it. If you can effectively bag valve mask, then wait till you get to a stable OR situation. But we need to make sure that we're able to oxygenate and ventilate. But a retrograde is using the fiber optic type stylet that's going to go down and out, and you're going to have to cut through the cricoid cartilage again with that. Again, I myself have never seen one perform. That doesn't mean that they don't do them. I just have never seen one. Okay, so now we're going to talk about some ventilation and some mechanical things. So we've got them intubated now, right? Now we need to put them on the vent. And we're going to look at your LTV that you all have. And the ventilator settings that I'm going to be talking about, you have accessible on the ventilators that you use in your LTV 100 and then your LTV 1200. They are available. The only thing that is not available is that last one, CPAP. You do not have the capability of doing CPAP, I believe.
We do.
You do.
We do.
We can't do PRVC, but we can do CPAP.
Okay, you put him in the pressure support mode, right?
Pretty much, yeah.
Okay. All right. Okay, so assist control. So let's go over a little bit about what assist control is. Assist control means that the machine is doing everything for you. If I go ahead and give you a tidal volume of 500, then the patient is going to receive 500 tidal volume. Doesn't matter if they want to receive it or they don't want to receive it, they're going to get it. Then I'm going to set a respiratory rate. And let's say I set your respiratory rate at 15. Then every one of those 15 breaths, that patient's going to receive that full 500 tidal volume. But let's say the patient's awake, he's alert, he's going to breathe 10 more times over that. So he's breathing a total of 25 times a minute. Those extra 10 breaths that he breathes all by himself, he's going to again get full 500 of tidal volume. Okay, so the machine is still fully controlling every single thing that he gets. Okay, so how is that different than, we'll skip to the SIMV first. How is that going to differ from the synchronized intermittent mandatory? Well, what happens in SIMV is, again, I'm going to set you a tidal volume of 500. I'm going to set you a respiratory rate of 15. For all those 15 breaths, he's going to get 500 of tidal volume. He breathes his extra 10. For those 10 breaths, he's only going to get what he wants. So let's say he's breathing and he only takes 200. But that's fine. That's okay. But that is the synchronized intermittent mandatory. So we are going to say you're going to get 15, you're going to get 500, no matter what, if you want it or not. But I want 10 more breaths, but I only take what I want. I'm not going to be forced to take anything extra of that. Okay? Any questions between those two? Okay, so pressure support ventilation. Basically, pressure support ventilation is you breathe it on your own. Okay, well, I give you just a little extra push, a little tiny bit of pressure, just a little extra flow in this pressure, and that makes it so that when you're breathing, let's say you're breathing on your own and I have no pressure support, and let's say you're taking 200 of a tidal volume. Okay, well then I say, well, 200 is not really effective. And you're not really getting a great breath. Plus your sats are not that great. So I'm going to add pressure support. And so I give you pressure support, and that is going to allow you to have that little extra jump. It's like stepping on a step stool. You can go a little higher, right? So you're giving him a little bit more of a push so he can take a bigger breath, a more effective breath. So I give him pressure support. Now he takes 400. So now he takes that better breath. But I'm not forcing him to. He's only using it up to what he wants. But it just helps out, just like that step stool, just a little helping. And you can add rate with that pressure support. So you can give a backup rate with that. And so that's when we talk about CPAP, that CPAP is not a mode of ventilation. In CPAP is just a continuous positive pressure, airway pressure, which means that if you think about it, when you have your hose and you've got the hose coming, it's a constant pressure through there, okay? And I can interrupt it if I want to, but it's just that constant pressure. And when the patient is breathing, he's only taking that constant pressure. I'm not giving him anything extra. Okay? He only gets that. Okay? And there is no backup rate in CPAP. Okay? They're breathing 100% on their own. If I give him a backup rate, then what's that's called is BiPAP. So I'm giving him a little, that way if he stops breathing, I'm going to breathe for him. Okay. Now for assist control and pressure and SIV, you do have the options of using either volume ventilation or pressure ventilation. Okay. In adults, you see mostly volume ventilation. Okay. In children and neonates, you're going to see pressure ventilation. And that's just because of the lungs. You really want to protect the lung. Okay. And with all of these, though, that you can cause volume trauma, barotrauma. You always want to make sure that we're still only giving what they need. You don't want to give a lot of excess. You're not looking for that huge chest rise or anything. You're still just looking for the chest to rise for your patient to oxygenate. We don't want big tidal volumes and big pressures. So any questions on that? Okay. So now this just kind of gives you a little bit of a visual picture of what it looks like. So we're just breathing here right now, right? This is just regular spontaneous breathing right here. Just breathing, okay? Well, I decide I'm going to help you out. So I'm going to give you a little bit of PEEP, okay? Now look. Now I can take some bigger breaths, some more effective breathing. Now this is what your assist control breath, whether it's volume or time cycle. When you're breathing, and assist control ventilation, like I said, the machine is going to do every single thing. So every breath, whether it is a vented breath or a spontaneous breath, is going to look identical on your screen. It's always going to be the exact same. So here's your inspiration, and then you go down into your expiration. Right? Your pressure cycled breaths, okay? Those are your pressure support, flow cycle breath. You notice every one of them is a little different. Because he's just breathing pressure support. You've given him, say, a pressure support of 15. He's just taking whatever he wants from that. He doesn't have to take a huge breath. He can take a little breath, a big breath. So he's just spontaneously breathing right there with whatever he needs. Here's your SIV breath. And look at the difference in these. So here's that machine breath. So here's your 500 going in. Whew. Okay. Here is his little, let's say 100 or 200 mLs of tidal volume of breathing he's doing here. It's all by himself. Then another big breath. Okay. So those aren't the greatest, most effective breathing, right? He is breathing on his own, which is always a plus, but it's not really that effective. So then I want to add that pressure support, that little step stool. So here's that machine breath, and then look, he's getting a better ventilation. He's getting a bigger tidal volume with those now, but he's still breathing on his own. People will ask, what is better, SIV or assist control? All depends on your patient and the clinical assessment and where you're at that time. Patient straight back from surgery, making no spontaneous efforts at all. The plan is to keep them asleep. No issue with them. Put them in assist control. We're not going to do anything with them. Because remember, pressure support that we're going to use in SIV is only useful if you're spontaneously breathing. So then your patient wakes up. Okay, now we want to actively try to get your patient off the ventilator. Then you're going to put them into SIV. Okay, put them in SIV, start weaning them down, getting them off the ventilator. Okay. Also, sometimes with chronic lung disease, you want to control them. If you have a patient that is just breathing extremely erratic, will not synchronize in with the ventilator, sometimes you're going to have to change those modes around. Does he want to breathe a little bit more on his own? Am I giving him too much in assist control? So maybe I need to try SIV? Or is he just breathing so fast in SIV that I need to knock him out and throw him in assist control? So again, this is all on your clinical assessment and watching your patient. Okay. So your initial ventilator settings. So some of the things that you're going to need to know, obviously when you guys go pick up a patient and they're on the ventilator, there are certain things that you guys want to know. You want to know what mode is he in. You want to know what initial FiO2 he's on. Now, if you have a patient that's in crisis or is beginning to go into crisis, you immediately go to 100% FiO2. Just go ahead and turn them up. You're not going to hurt them with that. You're looking at tidal volume ranges from an 8 to 10 mLs per kilo. That is your average for everybody. Now, when you're in the hospital, we do have different ranges based on some lung disease. So if you're an ARDS, we actually will use a 6 to 8 ml per kilo tidal volume. But again, that's our patient that's in the hospital where he's in ARDS. We've got him on the ARDSNet protocols, and that's a nationwide protocol that's used without the facilities. And that's just because they have such already pre-damaged lungs prior to us needing to mechanically ventilate them, that we want to use a smaller volume to prevent causing more damage to the lung. Okay? For your obstructive patient, your asthmatic, that COPD that's coming in for COPD exasperation. So if you're going to a home to pick up a patient, one of the things you're going to be looking at is using a very small tidal volume also with these patients, a 6 ml per kilo tidal volume, because they're so clamped down. If you tried to shove an 8 to 10 ml per kilo in there, you're going to possibly cause a pneumothorax, so you don't want to do that. So we keep them at a lower tidal volume range. And trying to remember, especially when you are getting these asthmatics and these bad COPDers, the goal is not to intubate them. They are very difficult to ventilate. These are your patients that are going to air trap, that are going to get the auto PEEP. These are the ones, when you get them on the vent, they're very difficult to get off of the ventilator. Okay? So if we can, we like to throw treatments at these guys. These are the ones that you're going to help with bronchodilators, giving these continuously while you're bringing them in, doing some non-invasive positive pressure, maybe just some real high flow back in the back of the ambulance, some high flow nasal cannula on them. It's not going to hurt them. Blow that CO2 out. That's what the concept behind the heated high flow systems is, that you are going to use higher flows to actually blow that CO2 out of that dead space so that you can bring their CO2 ranges down. All right, so your rate minute ventilation is appropriate to whatever your clinical need is. So that's going to be based upon what your patient is going. But the national range is from 10 to 12 breaths per minute if you're setting them on the ventilator. Now again, that is going to be changed around. If you have a patient that has no spontaneous respirations whatsoever, you've got them paralyzed, you're going to keep them out, you're going to increase your rate a little bit. Okay? If they're awake and breathing and you're weaning, you're going to decrease your rates a little bit. And then PEEP. PEEP is used to help support your oxygen. Okay? PEEP is your opening pressure that helps keep your alveoli open. It's a recruitment technique. It's also to make sure that we have adequate recruitment. If we're looking at a chest x-ray, make sure you're good 8 ribs to 9 ribs expanded, but no more than that. But having that expansion and having all that recruitment is what increases your oxygenation. So that's how it supports your oxygenation. So your inspiratory-expiratory ratio. A lot of people don't realize the effect that your inspiratory and expiratory time has on your peak airway pressures, your tidal volumes, your PEEPs, your CO2, your PaO2. There's a lot of things that are done in the background on ventilation that we can move around, that we can change without having to change that set tidal volume or the mode or that set rate. We can actually manipulate our inspiratory and expiratory time. So some of the determinants of our inspiratory time with volume ventilation is tidal volume, our inspiratory flow rates. Inadequate expiratory time. If I have an inadequate expiratory time, what's going to happen is I'm going to have that incomplete exhalation, like we saw in that one capnography where the patient was not able to get that CO2 back out. And then that causes breath stacking. If you've ever been and picked up a patient and they're on either an asthmatic or COPD and they're positioning themselves to breathe and they're breathing really, really fast, short breaths, what happens is that just stacks more up onto that chest and they're not able to get that air out. They're not, which means they're not going to ventilate and they're not going to oxygenate at all. So we've got him intubated. We're going to put him on some settings here in just a little bit. So what monitoring and assessment is usually needed after you get them on the vent? So when you pick them up, You're getting ready to take them out. Now, chest x-ray, I know you all don't have that in there. They do put that on there. I mean, obviously, if you're picking up a patient that's already on a vent and you're transporting them, I'm sure you're asking about what was that last chest x-ray like. You're checking epic, make sure that you had adequate placement, especially if it is an intratracheal tube, and even a trach. Make sure the trach is placed correctly. So having an idea of what your last chest x-ray is always essential. You're going to be monitoring those vital signs. Your CO2. I mean, you're going to be monitoring your CO2 off your capnography, but your saturations. Watching how the patient's synchronizing with the ventilator. If the patient is stressed out, which we know when we transport patients, they get a little stressed out. They might need a little bit of something to help relax them, but make sure they're synchronized. If they're not synchronizing, your ventilator can't work for you. It's going to alarm at you. It's not going to effectively ventilate, and your oxygen is going to start having an effect. Arterial blood gases. I'm not sure what trucks actually carry I-stats. I know some do, some don't. If they do have I-stat, checking either a venous or an arterial blood gas is great. If you have a long transport, it's definitely a good thing to see. If not, obviously getting your prior one to leaving a hospital is always a good thing. You can be looking at your inspiratory pressures. So for inspiratory pressures, you have a couple of them. You have your peak inspiratory pressure. Okay, that is the peak opening. It includes your PEEP, and the rest of the pressure needs to fully inflate that lung. It's a combination of both of those. You also have your plateau pressure. Now, your plateau pressure is one that has to be measured, and unfortunately, the LTV and most transport vents do not measure your plateau pressure. But it is a measurement that you can ask about whether we're having issues with your plateau. But if anybody was to ever ask you your plateau pressure, your goal is to keep that less than or equal to 30 centimeters of water pressure. Anything greater than that is going to look at some distension. You're going to have some alveolar distension going on with that, and you're going to have increased pressures, which we know is going to cause lung damage. With your peak inspiratory pressure, you're looking at keeping that under 40 centimeters of water pressure. Auto PEEP, you want no auto PEEP. This is what we talked about with that breath stacking, those fast respiratory rates. When you look at your ventilator is going to show you that I'm not going to return back to my normal set PEEP of 5. So I've set my PEEP at 5. I'm not going to return there. If I have auto PEEP, I'm going to be setting it maybe 10. I've had people with auto PEEPs of 20, which means that I'm not ever exhaling out completely. I'm staying open this whole time. So you have your PEEP, and here's your volume. So here's your breath, and your PEEP should come back to here. What's happening is I have my PEEP, and then I'm taking my breath, and I'm coming back here. And I'm taking a breath, and I'm coming back here. And so it'll just keep accumulating, and so they're only getting a little tiny bit of that tidal volume, and they can't get it back out. And then your ventilator alarms. You want to watch those alarms. So this is an example a little bit of that plateau pressure. So when you have your inspiration, you're going to come in. The patient is going to trigger it right here. Either the machine or the patient spontaneously will take a breath. It'll go up. Here's your peak inspiratory pressure. Now, I've done an expiratory hold on the mechanical ventilator here, and that's going to give me the plateau. Again, like I said, the LTV is not capable of doing that, but we can always get you that number, or you can obviously see it when you come into the hospital. And then I'm going to exhale out. This is what it actually looks like on a real ventilator right here. It's not as dramatic as this one, but it's showing me that I have a plateau that's slightly less than what my peak inspiratory pressure is running. So I need to make sure that if I have a high plateau greater than or equal to 30, there's some things I need to do to decrease that. The same thing with my peak inspiratory pressures. I need to decrease those things. Because with volume ventilation, I told you I wanted to get you 500 of volume. Well, I don't care what pressure it's going to take me to get there. I'm going to give you 500. Maybe it's only taking me 20 centimeters of water pressure to give it to you. But let's say you have very restrictive lungs, and it's going to take 50 to get through that 500. Well, that's not good. So we have to fix that, because that's bad to be that high of a peak inspiratory pressure. But in volume ventilation, remember, it doesn't care. It doesn't care at all. In pressure ventilation, I can set a pressure. I don't want you to have higher than 20 of the peak inspiratory pressure. And so the machine will go up, up, up. It'll hit 20 and calculate your tidal volume. Let's say I only gave you 200. So that's not adequate. I need more than that. So I either have to increase my peak inspiratory pressure or figure out why I'm not able to get a higher ventilation in there. So, oops. And there it shows you there our plateau pressure greater than less than equal to 30. Here's auto PEEP. This is what it does look like on the ventilator if you have graphics. What happens is, if you see here, it's not returning back to baseline. So this is your baseline PEEP of, let's say, 5. It's just not returning back. And then here, look at that. That is a lot of auto PEEP going on here. So some of our consequences of having auto PEEP, because I've had people tell me before, well, that means he's just going to oxygenate better because I have more auto PEEP, right? No, it's actually going to make your oxygenation worse, because as I showed you with our ventilations, if he was doing this and now he's only doing this, I no longer have that big tidal volume any longer. So guess what? He's not going to ventilate. He's not going to oxygenate because I'm giving him a little tiny tidal volume now because he's not able to get it back out. So it actually worsens your oxygenation versus some people's concept thinking that, oh, more PEEP, oh, it's auto PEEP. There is a difference with it. So it's not good for them. So it increases those inspiratory pressures. So we talked about those high pressures we didn't want. It can make your patient be hypotensive, and it worsens your oxygenation. So now why would it make your patient become hypotensive?
Because the lungs are overinflating and it's putting pressure on the heart?
Exactly. Anytime you add pressure anyways, anytime we add a ventilator, you're going to cause increased instrathoracic pressure. Okay? We know that. So we know if we already have a compromised patient that we're going to have to watch that blood pressure, because we know putting them on ventilation is going to make it a little bit worse. But if I have auto PEEP, which is all this excess pressure and they're just squeezing down more, it's going to make your patient even more hypotensive. Okay? Some interventions to decrease our auto PEEP. We can decrease our respiratory rate. Now this is either spontaneous or mechanical. So let's say you have that patient and you're on the vent and he's breathing 40 times a minute. We need to get that respiratory rate down. And some of the things we can look at is the patient uncomfortable in the mode. Maybe I've got him in SIMV and I need to put him over in assist control. Yeah, I'm going to switch him around, play with those things, see if I can do that. If that still doesn't work, I probably need some sedation. If they're breathing that fast, you need to capture them. So you need to bring that respiration down. And I'm not saying paralyze them. I'm saying sedate them. Ventilation is not a comfortable thing anyway, so a sedation is always a good thing to help with the auto PEEP. Decrease the tidal volume. So we had a 500. Maybe we need to come down a little bit. So we would decrease it by 1 ml per kilo at a time. So if we were at 500, we'd take 1 ml away from that, 1 ml per kilo. So you can decrease that tidal volume. And you can increase your gas flow rate.
FiO2.
No, gas flow rate. Gas flow rate, what that is what the rate of the gas is that's going inside the ventilator. Most of them have a preset. You can shorten your I time by increasing your expiratory time. That's how we play with those inspiratory times and expiratory times.
Because we can set I time.
Exactly. So if you had a patient,
shorten it, that's going to...
You'll have a longer time to exhale, which means you're going to be able to blow out that CO2. So when you have auto PEEP, yes, decrease your I time. Cool. Now, what happens when I decrease my I time though?
It's going to push the breath in harder because it's got to get that, especially if you're in volume, you've got to get that volume in, and instead of over 1.2 seconds now, you're going to put it in over 1 second.
Right.
You're still putting in 500, but you're going to be putting it in 25% less time.
Yes. And it can increase that inspiratory pressure. So it is, like I said, it's going to go in there faster, so you might increase your inspiratory pressure. But the other thing that it's going to do is it's going to affect your oxygenation. Because now I've decreased my inspiratory time, so I have a longer time to get that CO2 out. Okay?
So there's more room
and to get all that auto PEEP out of there. So now I have less time to oxygenate. Okay? So it works in the same way. If I have an oxygenation problem and I'm already at 100% FiO2 and my oxygen is still low and I can't get my SATs up, I can increase that inspiratory time and give me a longer time to be able to oxygenate all my cells. But then I'm shortening my expiratory time. So I'm going to see an increase in what?
In total CO2.
You're going to see an in-total CO2 increase. So that's one of the things that we want to show you on management of ventilation is that every single thing that you're going to change has another effect somewhere else. And sometimes we have to make the decision, do I want to be hypercapnic? We're going to accept that, which some of your patient population you will. Asthmatics, COPDers, hypercapnia is okay. We're not worried about them at all. Let them have that higher CO2. Let's get that oxygen in there. We can accept that. Other patients, The docs don't want that. They want that low, normal CO2, and sometimes they're willing to sacrifice their oxygen. Some want it all. Unfortunately, unless we have the perfect patient, we can't give you it all, but we try our best. But yes, manipulating your inspiratory, expiratory time, which you do have the capability of doing on your ventilators, is essential in that.
Well, then when you have your stroke patients that you're having to ventilate because they've lost their drive, you want to keep their CO2 high or low?
For a stroke patient, it's affecting neuro. Traditionally, with anything that affects the neuro system, we try to keep your CO2s on the low side.
Right.
Because it preserves. So we would try to keep their CO2.
It'll also cause ICP.
Exactly.
And increased perfusion.
Exactly. So yes. So a stroke patient, you would not want hypercapnia. You would go more for the oxygenation versus you would go for that low CO2. Okay. Remembering not going less than 35, please. When you go less than 35, that also has dire consequences on your intracranial pressures and on the nerves and everything in the brain. So, all right, so those are some of our interventions with that. So what changes in ventilator settings would improve oxygen, which we've already talked about that a little bit. So FiO2, obviously, you can increase your FiO2. Your mean airway pressure. So what affects that mean airway pressure? Our tidal volume. So to improve oxygenation, I can increase my tidal volume. Right? I can play with that IE ratio. Okay, for oxygenation, I want that longer inspiratory time. PEEP, you can add PEEP for oxygenation. Let's say I'm on 5 of PEEP, but I don't seem to be recruiting very well. I'm going to go up. I'm going to go up to 7, 8, 9, 10. We've had people on very high PEEPs. PEEP is the least damaging of any of the pressures that you can actually apply to a patient's lung. So we always say optimize your PEEP. Get that PEEP, use it as well as you can. Okay? And then auto PEEP. We know that, we just saw, is actually the opposite on oxygenation. So we want to make sure that we're decreasing any auto PEEP that we have going on. Okay? So those are a few things that will affect our oxygenation and things that you can adjust on your ventilator so that you can get a better oxygenation. So what are the consequences of making these vent changes? So if I increase my PEEP and I increase my tidal volume, what do you think is going to happen?
Pressures.
Increasing your pressures, okay. Cause more barotrauma, volume trauma, okay.
You're going to drop the blood pressure.
Exactly, you'll become more hypertensive.
Increased cardiac load.
Exactly.
Or could have better oxygenation.
You could be increasing your oxygenation. That might be what you're going for. You have an increase in your oxygenation. Okay? So you can have your increased peak airway pressures, an increase in oxygenation, and a decrease in our cardiac output. So all the things you guys said. Very good. All right, so what changes in parameters would improve ventilation? So respiratory rate, obviously. So if I have a ventilation issue, I have a high CO2, I can adjust my respiratory rate. I need to increase it. Okay? I can play with that inspiratory, expiratory time like we just talked about. If I have a high CO2, I'm at a respiratory rate that I think is an optimal respiratory rate, but I haven't optimized my expiratory time, I can increase that expiratory time. Blow that CO2 out of there. Okay? And you can look at your mode of ventilation. Okay, that has a lot to do with it too. Am I in SIMV, breathing 50, 60 times a minute? If I am, sedate me, put me in assist control. Am I uncomfortable? Am I in assist control and I'm breathing 30 times a minute, but I'm not heavily sedated? So the machine is giving me, these huge breaths, and I am uncomfortable. I'm fighting the vent. Switch me over to SIMV. See if I feel better. See if that brings my respiratory rate down, because now I'm able to control it myself a little bit. Because maybe I had too much tidal volume going on over there. Or maybe I wanted more. Maybe they only gave me 300 and I want 400. So play with your modes of ventilation. You make those suggestions of looking at those. So here's a case study. So you guys have a 70-year-old patient with a long history of smoking. So we can already probably deduce that this patient probably has some kind of chronic illness, right? He was intubated for respiratory distress. He was intubated, he was sedated, and he's now on mechanical ventilation. Now always make sure that when we're adjusting and talking about tidal volumes, that we are looking at our predicted body weight. We're not looking at the actual body weight. The reasoning why is because I'm 5'1", okay? But let's say I weigh 300 pounds. If you calculate it on my actual 300 pounds, that's a lot of volume. I might be 300 pounds, but my lungs are not. So you always want to, and that's why it's based off of weight and your height. So you want to try and use predicted if at all possible. This is the calculation for male. There is another one, and it's 40.5 plus, I didn't put that one in here, I'm sorry. And it will give you, for female. So it is different from male to females with your predicted weight. If you don't have anybody, if you don't have their actual weight, you're going to look at the patient, and unfortunately you got to kind of make a guess, or maybe ask the patient how much they weigh if you don't have the ability to weigh them or get their height. Okay? And just use your best judgment. You know, we've all seen patients, we all kind of form ideas in our head, so just use your best guess with that. Well, your low blood pressure alarm is sounding with this patient right now. Okay, so we need to look at his vent. So what ventilator settings would you recommend? What mode would you like to put him in?
He's sedated, right?
He is sedated.
I'd probably opt for
Does he
the
have
assist control.
drive?
I'm sorry, what?
Does he still have a drive?
It doesn't, the information doesn't give you that. Only that he has been sedated and he is intubated. But he's not saying if he's breathing spontaneously any on his own right now.
I'd still go assist control as my vote, because then we can give him the bronchodilators, we can control his respirations and try to get him back on track.
Okay. What FiO2 would you want to give him?
100. He's under
100.
stress.
Very good.
100.
Yep, 100. So it's tidal volume. When we looked at the previous one and it gives you use your predicted volume and everything, it actually calculates up to approximately 70 kilos. And so they always tell you to go to the high side, so the 8 to 10 start him out about 700. Now in real life, I'll just tell you, this is how the scenario goes. Yeah, you would go towards the low side, and you'll see that'll be one thing as we're changing as we're going through our scenario. Okay, but if you were going to put them on, what would you want to do? So 70 kilos, and you wanted to go an 8 kilo. How much are you going to give him?
Yeah,
70
six.
kilos, 150-pound patient, 450.
Mm-hmm. Okay, so and his rate. What kind of rate would you want to start him out at?
Like 12.
12, okay, because you want to start, this is your initials. So you want to stay between that 10 and that 12 at the very beginning, just as you're initially putting him on the ventilator. And then what peak?
5.
Standard of 5.
5. Always start at the 5. Okay, and then we're going to adjust it based on oxygenation and chest expansion. All right, so they chose SIMV, got 100%. Like I said, they were going to. I told you they were going to choose 700. You got a rate of 12
Anybody say balloon?
and a peep of 5.
Christmas parade?
I'm telling you, there are things, but now we got a problem, right?
Although I've seen that I've seen that recently out at the Bryan Center. But we're talking about like rates of 10, 8, and volumes of 7, 750.
Whoa. See, back years ago, 20 plus years ago, we were high rates. It was 10 mLs. That way everybody got 10 mLs per kilo. So having high rates now high tidal volumes is very unusual now. We just do not know. We know that it causes volume trauma. And so we want to use, like I said, the least amount of volume to actually ventilate and get a good chest rise without causing damage. So this was your blood gas on this patient. And as you see, we have some problems. So we're not ventilating very well. We look at our pH, and that's one thing that we always want to try to emphasize is don't always pay attention to that CO2 as much. I mean, obviously you want to be aware of it, but look at that pH.
He's really acidotic.
Very, very acidotic. So we've got a problem with that. And then look at our pressures. Now, we said we wanted our plateau less than equal to 30, so we're 35. And our peaks, we wanted less than equal to 40, and we're at 50 now. Yeah. And look at that. We have an auto peak of 8.
He's really struggling to get that air in.
He is. And he is breathing spontaneous a little bit. So we gave him, what did we say, rated 12. So he's breathing 6 over that. And then look at his blood pressure and his heart rate. He's got a heart rate of 130. He is very uncomfortable, he is not doing well.
Could we give him like a bronchodilator or something to kind of help him get some of that air out?
Yes, you could give him a bronchodilator.
Knowing his history.
Sooner than later, we can just increase his pressure and lower his tidal volume, probably. So if he was getting that high 700 tidal volume, so we want him to breathe a little bit faster, but we don't want to breathe in. If he was rated 12, we could bring him up to. We could make sure he is on SIMV instead of assist control, since he does have some intrinsic respiratory rate.
Okay.
But I would bring his tidal volume down, and then increase his rate up a little bit.
Okay, so everybody agrees the 700 is way too high.
Yeah.
Right? We won't bring that down. Okay. That's one of the first things, because that high tidal volume is doing what, too?
Pushing all that
I
extra
put-
air.
Causing autopeep.
Yeah, and it's causing you autopeep, it's causing hypotensive. So that high tidal volume is not doing us very good.
Yeah.
So what's causing our possible hypotension? The positive is thoracic pressure. Our autopeep, he's hypovolemic.
He blew his lung out.
I didn't. I tried not to. I know, I tried not to. But yes, we probably have a pneumothorax now. And possible myocardial ischemia. So this is his current settings, right? His SIV is on 100% with a 700 tidal volume, a rate of 12, a PEEP of 5. This was our blood gas. This is our auto PEEP, our eye time. Immediately, we said we want that tidal volume down.
So what is our eye time? 1?
It's a 1 to 1.5. So he's got a pretty high eye time.
So 1 in, 1.5 out.
And a rate of what? 12?
12. But he's
12
breathing
to
18.
20.
So he has got a rate of
5
12.
seconds per breath. Okay.
So we can definitely increase our eye time also. I mean, we can increase our expiratory time also by decreasing our eye time. But this is our biggest thing. This is causing all that hypotension. So we need to probably get down on that immediately. So now let's talk about the consequences of those. So we just dropped our our tidal volume down, and we're probably sitting about 500 now. Okay. So what would that 500, dropping from 700 to 500, what kind of a consequence can we see with that now?
It's going to become, his SpO2 is going to drop.
Less oxygenation.
Less oxygenation, very good.
Less air that actually goes into the functional alveoli since he's been a long-term smoker. Some of his are damaged, so they're not functioning anyways.
But,
And he's got an increased anatomical dead space.
but if he's a smoker and he's got obstruction, we can increase his pressure and decrease his volume and get it in deeper with the pressure versus the volume.
You want to stay a little bit, you want to go increase your PEEP. We want to get that auto PEEP
Right.
down, which is one of the things that decreasing our tidal is going to do. And then we want to increase our PEEP from that 5. We'll probably want to go up to say probably a PEEP of 8. So that's going to help compromise with that. So we've come down on our tidal volume, but we've increased that PEEP a little bit. So now I've got more sustaining open pressure to recruit that lung because I am a COPD, or I've got so much that's unrecruited in there. And now I've got that bigger opening pressure there. Now I'm going to have that good tidal volume, but it's not going to be that 700 excessive amount of tidal volume. So you're going to fix your oxygenation by increasing your PEEP a little bit, and then you're going to decrease that tidal volume. But we know he is a possible chronic patient anyways, so we're okay that by decreasing the tidal volume, what's it going to do to our CO2?
Allow it to escape.
Well, by decreasing your tidal volume, there's a chance that you're going to increase your CO2. Now, we know that hypercapnia is okay, but a 7.2 is not. So we want to make sure that we watch that. So we can fix that by increasing our expiratory time a little bit. So we decreased our rate. So we had a rate of 12, but he's breathing 18 times a minute. Would that have any effect if we decreased our rate, say, to 10?
No,
It's actually, exactly.
He's still spontaneously going to breathe over the vent.
Exactly. Remember that if you are setting at a rate of, say, 12, and he is breathing 18 times a minute, by decreasing it to 10 is not going to change that at all. Okay? Change to assist control, like we had suggested at the very beginning here, is that assist control is probably going to be a better mode for this gentleman. One, we can get those 18 breaths are now going to be full ventilator breaths, so he's going to get the full advantage of those instead of probably the short, quick ones that he was getting in SIMV. So assist control and volume is going to be a better mode of ventilation for this patient and hopefully make him a little bit more comfortable. What can happen when they're in a mode that is not comfortable is they get real air hungry. and they'll start taking very quick, very short breaths, and that increases our what? Those quick, short breaths that they can't exhale increases our
inspiratory pressure.
Our inspiratory pressure, but also our auto-P. So they breath stack, and COPDers are notorious for breath stacking anyways. So we want to go ahead and make them comfortable and take control of them so that we can get that out of there. Okay? Any questions on that? All right. Questions part didn't come out the great there. I know it's a lot. I really do. But the one thing that we try to get everybody to understand, and just so you know, throughout medical professions, people still don't understand what every single ventilator setting and knob, by making the different changes, that it does have an effect on something else, whether it has an effect on something else I'm delivering to you or a consequence that's going to happen because I'm delivering something differently. And in patients that are chronic, you are going to have to decide if you want to oxygenate or if you want to ventilate, or you're just not going to be able to get both all the time. Okay. Now, did you want me to pull out your LTV?
Yeah, we can do that.
I volunteer Will to be intubated.
Will to be intubated?
I can drag this out
How
to the
about
bottom
these?
too if you want.
Only me.
So that way you can have it down there in the camera view.
Oh, down there? Okay.
One of those is the 1200 and one of them is the 1000 circuit, just so you can show the difference.
Okay.
Like I said, that's the big thing that our providers are stressing to now.
Oh yeah, going down
She
here.
wanted me to bring it down.
Yeah, the camera can't see at the front of the table. Yeah, stuff falls up there. I can always adjust the camera.
You don't
Just
have
add
That's
the
the
little line.
1000 circuit. So.
Yeah. I have a training circuit as well if you want to open it and do all that
Okay.
stuff.
No, okay. All right.
It's just you can still see the PEEP valve in there and
Yes.
everything.
And that's the main thing to understand, and the difference in them.
Yeah, it is.
Is
Yeah.
that in the
The 1000.
the older LTVs, the 1000s, your PEEP valve is in the circuit. Okay? That means it's not available on your ventilator itself, and that does not have the capability of PEEP. So you have to set your PEEP through the PEEP valve that's actually on the circuit itself. When you pick up the LTV 1200, you're going to see that it does not have that PEEP valve inside there. And the PEEP is actually built into the ventilator itself, and it's another setting that you're going to pick and place on there for your patient. So that's always a good thing. Now, the LTV, sorry, pick it up.
Yeah, it's like a brick.
I know it is. Okay. I don't know which way to hold it. Like that? Is that how they will see it?
I don't think
towards
they're
me.
gonna. I don't
Doesn't
think they're
matter?
gonna see it anyways.
Okay.
It's
Well-
just so that way we're in the view. I could try to
That's
zoom.
all right. All right, so the LTV, I'll put him up on his battery here. So this is the LTV 1000, which they're wonderful in the fact that I have the ability to use the assist control that we've already talked about. You have SIV, you have CPAP in here. You can choose to either do volumes or pressures with this. You can do inspiratory holds, and expiratory holds if you need them. You're going to be able to monitor all the settings that you're going to put in. Plus, when you go into the select stage, which some people are really good at doing, and other people completely forget about it. But when we talked about our tidal volumes and our peak inspiratory pressures, mean airway pressures, you're looking at your minute ventilations, that's where you're going to find in your select. Okay? I think it'll just alarm me if I turn it on.
Yeah.
Did you get the Tesla on?
Tesla's in the closet.
Okay. I don't know if it'll let me get past it now, so don't let me get past it. Because I have an alarm. That's the one thing too. If you have an alarm, an active alarm, it will not let you get past. Here we. Oh, there we go. Okay. So when you get into the
Yeah, it's gonna constantly.
select, what you can do is you can see your peak inspiratory pressure. Okay. Then you're going to be able to see your mean airway pressure. Go away. Your PEEP, and then remember you're dialing this one in off of your circuit. But again, you just dial it, you push and dial. It's going to let you know what rate you have set, and then also what the patient is actually breathing. There's your tidal volumes. Okay, minute ventilation, your IE ratio. Okay, that's going to be your calculated amount of volume, of flow that you're actually giving to your patient. So that's your flow rates. Alarms, wonderful. Now, if you hold it, okay, if you hold that select button, what happens then is you get into your alarms. So you're going to be able to go through alarms, operationals, your ventilator alarms. Okay, it'll be able to trace events, and then you can exit through there. So if you went to event alarms, and you hit select again, and in here it's going to allow you to set times. And your rise time, if you've never set rise time, what rise time does is it actually makes the breath, when we talked about adjusting our inspiratory and expiratory times earlier, rise time makes the breath either a smoother or a sharper breath. It's just the way it just turns the flow. So
It had a value of 4?
yes, this was in a flow of 4. It goes from 1 to 4.
Okay.
4 makes it the smoothest. Oh, thank you.
Yeah, that might help make it
We
quiet.
need that little piece. Oh, okay.
I got both of them.
Yeah, I can take that off. Can you get that one off? Maybe. Just like there. Okay, perfect. All right. So your flow is going to go, your rise time flow is going to go from 1 to 4. Your 4 makes it the softest of the flow going in.
Gotcha.
So keeping it at a flow of 4 is just fine. But if you have a patient that you're still having some trouble ventilating, you can go ahead and change your flows a little bit with that.
Because it's not plugged
Oh, it
in
needs
the
to be plugged
battery.
in too.
Here's this.
All right.
No, what you need to do is dial your FO2 down to 0 to 20.
It's at
I am at
21.
21.
Okay.
It's a disconnect alarm.
Get under there.
This one has a battery. They took the battery with them probably.
Okay, there we go. Look at that.
Yay.
All right. So, really?
It wants green oxygen.
Still saying disconnect.
Something else thinking?
Dial it down to 0 and see if it stops doing it.
It won't go to 0. It goes to
Oh, it
21.
only goes to 21. Okay.
There we go. That was just loose.
Okay.
Okay, so we're at a profile of 4 in your rise time. Profile of 4 is going to give you that softer flow going in. As you go down, so if I wanted to go down 1, 2, 3, 4, and we'll see if it will show you a difference on your lung.
Get me from.
Half a lung too. Look at that.
Okay, so like I said, a profile of 4 is perfect to keep for a rise time. So flow termination. Now this is set at a percent of peak of 25. What this is saying is that it's going to terminate the flow. So we talked about, let's say you have a patient that it's a trach patient, and they have a large leak, and it is just, the flow just going. It's trying to give you that 500, okay? And it's going and going, and it can't deliver it because it keeps leaking everywhere. So flow termination is what you set that will terminate it at a specific time. It's going to say, I cannot reach that flow or that volumes, so I'm going to terminate this and go to an exhalation phase. This is best set 30. And what that tells you is that at 30% of unable to reach that peak, it's going to go ahead and terminate that exit.
So if it's supposed to give 500,
It's going to try to give the 500.
and then once it gets to 60,
It's going to go ahead and say, no, it's going to try to give you the 500.
and once it gets to 560,
And it can't give
and
it.
it can't get it in there,
It's going to go to exhalation. Okay? And that's for the safety of your patient. It's just not going to just keep blowing and blowing. Without
Default
having,
setting to 25?
yes.
Okay.
But always go to 30. But if you don't have that set, then it would just keep blowing and blowing and blowing. Okay?
and it's already defaulted.
This one was set at 25. So I'm not sure if that's the default when you turn it off, but it should stay whatever you've had it set in. All right, so and then time termination, this says it'll terminate at 1.5 seconds. And that's mainly because you've got an I time set. We're in SIMV, you have an I time set of 1. So it's going to terminate at that 1.5 seconds. I'm not changing that. That's going to be set by your I time. Okay. Then you've got your flow termination, on or off. We always want to keep that on. Leak compensation, you can have it on or off. Always keep your leak compensation on, because the machine is not going to give you all these erroneous alarms if you let it compensate for your circuit. And that's what it's doing, is it's trying to, it's taking in the leak and the circuit, and it's trying to compensate for that. And so it'll adjust the flows the way it needs to for that. And then non-invasive positive pressure mode. I don't think you all use that. Okay, then let's not play with it. O2 flush. Flush. No, I'll never use that. And then your controls unlocked or locked. You can change your language on this. I do have to say we have done that on occasion just to be funny. You can put your date and your time so that when you go back and look at your the trends, you can have a set date and time. You can just change so many things when you're inside there. This will tell you when you're on your O2 cell, it will tell you how long your duration should be, depending on the settings that you have set in there, which is nice to have. You don't have to do that calculation.
Is it basing it on the pressure that it's getting?
Yes, it's based on the pressure it's getting.
So it does. You don't have to put anything in there. You just hook it up and it'll read it itself.
No, well, it asks you your cylinder type.
Oh, you have to put the information.
Yeah, you have to put the information in, but and how many psi you have in it, and then it'll calculate it out.
And currently we can go for 100 hours.
You can't say 1,000. So it really does have a lot of good things inside there that you can mess with. Always just make sure that you exit back out, and that's by using your select button. Going back through all those, so you get the exit, hit that, and then it's going to take you, and here's your alarm. You can change the volume of the alarm, your apnea intervals, your high pressure delay, the low pressure alarms, your high frequency rate. Because if you notice, the only one you have here on the front is your high pressure limit, your low pressure limit, your low minutability. That's it. But what if you have that patient that has a really high respiration, okay, and you can't get them to calm down? You might need to go in here and change your high respiratory rate. And to change anything, you hit select, and then you dial. Okay? You can turn the high off. Okay, you set it at 80, and then in wherever you want with that. Then you just hit select again, and always making sure when you're coming back out, you always hit the exit button. You set your high peep alarms.
That's good for our little lady at Avante, remember her? Stays at like 30 or 40.
And that's the thing, it's so people just automatically assume, oh, well, all patients are going to be the same thing. So it is nice to have that in the background. We use ours mainly for transport at the hospital, so we don't make a whole lot of changes in those. But as you said, the Avante, the Brighton Center, this is their main vent. They're on LTVs. So being able to go in and fine-tune that to the patient is a wonderful thing.
Now, when you go to those centers, like the Bryan Center, for example, we're 45 minutes away and we're called there for a sick patient, and we think it's something of a respiratory nature, what is going to be the first thing we change on a chronic ventilator patient if we think something's going on?
Okay, so you arrive there, and it's going to be dependent on what the patient is doing.
The trach.
Like, we think they got pneumonia. They get pneumonia there all the time. One of the nasties that's going around.
Okay.
They've got pneumonia.
So you first thing you would want to do is you want to up their FiO2. So I would go ahead and put them up to 100%. You come in to pick them up because there's an emergency. Mm-hmm. They're in a crisis of some sort. I would go ahead and turn their oxygenation up. Go ahead and give them that higher FiO2. Okay. And then when you're looking at your patient, you know, they're obviously on their own preset settings all the time. You want to listen to them. Are they getting the volume in? Do their peeps look okay? Does their rates look good? If they're more obtunded, and they're a trach patient, you might have to increase that rate. And that's a lot of times what's happening is either they're going to be hyper breathing, they're going to be breathing too fast because they're uncomfortable and they're air hungry, they can't get it in, or they're going to be breathing 2 or 3 times a minute, or only what the ventilator is giving them.
Okay.
So I don't know if they draw gases over there. Do you
They
have
do,
a
and
gas?
then you get a result like 2 days later.
Oh, okay. So that doesn't help you much in your decision-making process. I would definitely look at your patient and based on your patient's clinical assessment. If you don't feel the patient is getting adequate enough rate, you would go ahead and check your rate.
Because we have the end title on the trucks, we have the end title
Okay.
and the SBO2 that we can use like right then and
Then
there.
I would definitely put them on the end title.
And that'll
just
hook
use
up
that.
right in line with our vent service.
Exactly.
So, awesome.
So put your end title on and look at it and think back to the graphs that we just saw and look, are you obstructed? You know, so it could be that pneumonia patient and they need some treatments. They need to be opened up because they probably have an underlying COPD in there anyways. So if you look and you see a waveform on that on your capnography and it's showing that you're not exhaling completely, put some treatments in. Load that neb up, give them a continuous neb all the way back here on their 100%, watching the rate. If they need a higher rate, give them a higher rate. Okay?
Got it.
I'm not sure on what they allow you guys to change, or if you just have to call the doctors or whatever with that.
Most of the time we can change, the things we can change are the rate and the FiO2.
Okay.
Tidal volume is kind of up in the air.
Depending.
We don't change vent modes. Giving the patient a couple extra breaths has always been okay, and giving them a little extra O2 has always been okay. The tidal volume is, most things if you do it, they're not going to kill you, but they don't like us to
Right.
change that too much.
And a lot of it's because you can't check X-ray, those kinds of things. And like I said, you're not being able to get a gas,
Yeah.
which kind of hinders you there a little bit. But I'd turn the rate up a little bit, help them out a little bit more. Definitely put them on 100% FiO2. Like I said, you're coming there for a reason to get these guys.
Like our 700 ones down there are some at the Brown Center, and they keep it 700. If we down some of them, they'd probably be cool with that. But
It's high.
they literally, they stay there. Like that's
What are
their,
their
But see, that's the other
pressures
thing.
run?
There's
That's-
a lot of
their lung
there's
compliance is
two
just
different.
gone.
The Brown Center's got two different groups. You've got the group of lung disease patients that are chronic vents because of failure, and then you've got all of the chronic failures because of loss of control, because they have the TBIs, the strokes.
Right.
So all of those, it's not a lung problem. It's nothing causing them to breathe.
Right. They have no
They have no
spontaneous.
respiratory drive.
They have no respiratory drive. 700 is still high. What do their pressures run usually? Do you remember?
Most of the ones, the couple that I've seen like that, they're running 25, 28, 30.
Not high pressures then. I mean, they're not really.
Yeah, it's interesting when I come across one of them.
Maps of like 12 and 14.
Now that map's a little high. You like to have single digit in your map. Now, of course, that's a more normal one.
What is our highest map? What do we want?
You can't change the map. The map is
To
completely.
look out for though.
Oh,
You
I
said
think it's a
single
map of
digit
20, but map of 20 is excessive. You
Yeah.
want to stay down. I believe it's less than 12. On your
Okay.
Because your map
12
is going to be boosted by your auto peep.
Your map, it's affected by your peak inspiratory pressures, your peaks. All of your pressures are going to be what's going to give you what your map is.
12. So.
Because it's the mean of all of those pressures combined together. So you do want to keep your maps down though.
So let me ask you this, I'll give you a for instance. You've got a 500-pound patient, 6'8". He is already on
He's on like 20,
20
pressure control.
20 of, he's on volume.
Or is it peak that he's on?
He's on volume, he's on 20 of pressure support and 10 of PEEP.
10 of peak, 20 of pressure support. Okay.
No, he's on 25 and 5, I'm sorry.
So he's on 25 pressure support and 5 of peak.
I'm pretty sure he's on 10 now, but
He may be on 10, yeah, now.
yeah, he's one of our frequent flyer guys.
Okay, because if he was on 5 of peak, the first thing I'm going to tell you is up that peak.
Yeah, no, he's on like 10 because he's in.
But
He's on a
volume-wise, I don't think he's on, but like, I want to say he was only on like 550.
You're welcome. It was nice to meet you.
Thank you.
I will.
Bye.
So he was on about 550.
Yeah.
Okay. And what is he getting with his pressure support breaths? Because if he's got pressure support, that means he's spontaneously breathing also. Is he still pulling around that 500 with his pressure supports breath, or is he pulling more with that?
I don't remember.
Pulling 350s, 400s.
Okay, which is good. You want to get at least half.
See, the problem was we transported
set
him.
tidal volume.
We
Or
transported him for 3 hours, and he either high pressure, low pressure, apnea. I mean, it was just every freaking alarm that could go off on it.
Is that the BiPAP guy that we put on CPAP just so we could transport him?
No.
Okay, because there's another one.
This is 600 out of Winston that came up here.
Okay, because there's one at the Bryan Center that's the same settings, but he's a BiPAP patient, and we put him on CPAP just so we can transport him, and they'll put him back on BiPAP because it's out of our scope and what we can do.
Why don't they just let you put him on an SIMV with like a rate of 5
It's
instead
something
of
like
doing,
that.
because you can transport a vented patient, but they
We
won't
can't.
let you transport a BiPAP patient.
Yeah,
Now, is he intubated? Is he on a
trach.
mask? He's trach.
he's trach.
We can't transport intubated patients.
But you can transport trach patients.
Yes.
Yeah.
My suggestion is
That's where they
anytime you
draw
have
this
to-
line between us and lifeguard. That is the intubated and trach BiPAP.
Well, I think we can
Trach
transport.
is
We
the
can
same
transport
thing.
it.
That's a lie.
We can transport an intubated patient as long as they're not being chemically sedated.
No. The last intubated patient I transported had to have an RN and an RT ride with to manage the vent and the patient and the sedation and everything else.
Yeah, that's what I'm saying.
He was sedated, but
Sedated. If they're intubated and they're not sedated,
unless we put it in there, we still don't transport them there.
okay.
Yeah.
But so he's a trach patient, and they're switching him from BiPAP to CPAP. One, if he really truly needs the BiPAP, that's not a good thing for him. But if they just switched him over to SIMV with the same type of volumes he's pulling on his BiPAP, so let's say on his BiPAP trach he's pulling 400. So put him on a 400 with a rate of 5 and pressure support, and you've got the exact same thing almost. And then you transport him, and he's got that rate. So if he needs it, he has it. In CPAP, all he has is basically PEEP. That's it. He doesn't have that other pressure to help keep him open. So he's going to become atelectic on you, and there's a good chance he's going to become apneic on you. So you're going to have an increased CO2 by the time you arrive where you want. So the suggestion next time would be see if they, instead of making put him on CPAP, if they'll just let you throw him an SIMV at a small rate and a tidal volume equal to what he's doing on his machine there, a volunteer, wherever you're picking him up.
Yeah, he's out at the Bryan Center. He gets real antsy and worked up, bless his heart, but and then it doesn't help.
He can't breathe well.
No, I mean that's as soon as he sees us on
Oh.
any event, he gets worked up, bless his heart. And then,
And it's hard because even though they're going on their machine or your machine and it's similar, it's still different for them. I mean, it's if you go from the LTV 1000 to the LTV 12, some patients are going to notice the change in that. And they can notice the way the flows come. And There's no explanation really for it. It's just every ventilator is a little
They
bit
all
different.
do the exact same thing, but
But
they
they-
all do it just a little
A
bit
little
different.
bit differently. Some can tolerate, some can't, some love it, some hate it. So it could be kind of a thing. But so your patient you were asking about is on the 500 volume. He's on that high pressure support, the PEEP. So what was your question about him?
So he starts to have trouble breathing. He starts to become tachypnic.
Okay, start breathing too fast. Okay,
What can I do to slow him down?
okay. One,
Besides,
besides sedating.
yeah.
Okay. First thing is look at your tidal volume. Does it seem like it is adequate enough for him? Being transported in, he might need a little bit more supported breath. So he's on that pressure support already. The good thing is to look to see what is his pressure support's breath versus what his given breath is. Maybe he needs a little bit more pressure support. Okay? Or you might need to increase his tidal volume just a little bit for the ride over. Check your rate. Is he on a rate of anything significant?
No rate.
No rate. Give him a rate. Help him out. Okay? He's going to be anxious. So start him at a rate of 10. And then that way he's going to get some good, nice breaths along with taking his pressure support breath. And he might be a little bit more comfortable for you. I'm not saying he's going to be 100% comfortable, but I might be able to make the ride a little bit better. And explaining to him what you're going to do and see if that'll make him comfortable. And a lot of times I'll talk to chronic vent patients when I'm making changes, and I'll be like, well, does this one feel a little better? And sometimes just asking them, and you're not really hardly making any change at all, they seem to do better. And maybe increase his eye time. Maybe he wants a little bit more flow going in there. And since you can play with those numbers, that's something that you can look to make them comfortable and see how they do. Because just by playing with your inspiratory time, you can actually see the work of breathing of some of these patients coming down. And check your sensitivity. Is he able to breathe on this very well? Because we have our sensitivity set at 1. You might need to increase that a little bit so that it's not so hard for him to take a breath. And so maybe make it a 3 or 4 and watch him and see if he's able to take that breath a little bit, because he might be fighting the machine. Are you guys setting it exactly like the ones that they have there?
Usually, yeah.
Okay.
But usually it's copy and paste from whatever we're given.
Yeah, watch the sensitivity, because I still have my people, they'll just leave it straight at 1, and that makes it harder for them. The flow is there, but remember, they've got to make some sort of either the machine is going to give him, so this time it's going to go, and 14 times it's going to shoot a breath at
So
him.
the lower the number, the harder it is to breathe?
Mm-hmm.
I thought it was the other way around.
You want to go up a little bit. We always leave ours about 2, and they seem to do okay. But that's the thing, is sometimes it's just too much for them to take that breath. So just kind of play with it and just kind of see what they're on there at their machine. Anything?
I think that covers it. The recording actually shut off about 5 minutes ago too.
Oh, did it? Oh.
Yeah, it cuts off automatically at 8:30.